Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's program is a special collaboration between the Blum Center and Cancer Center at Mass General. Before I get started, I just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, our co-host, and guest speakers will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. So next, I am going to hand it over to Devin Punch. She is Mass General Cancer Center's health educator, and she will introduce you all to today's guest speakers.
Thank you, Amy. Thank you, everyone, for being here today. Thank you to our speakers. We're excited to hear this very important talk today. We are joined today by Dr. Kelly Irwin. She is a psychiatrist and health services researcher. She founded the Collaborative Care and Community Engagement Program at Mass General Cancer Center, as well as the Engage Initiative, which is a coalition dedicated to ensuring that mental illness is never a barrier to cancer care. She is an assistant professor of psychiatry at Harvard Medical School. Amy Corvaline is here as well. She is an oncology social worker and serves as the associate director of the Collaborative Care and Community Engagement Program. Shakria Brown, thank you for being here as well. She's the community health navigator for the Collaborative Care Program and has a background in community mental health. I will turn it over to you now.
Thanks so much, Devin. Thanks everybody for joining us. We're a team, so we wanted to all, talk with you together, especially when we have the opportunity to engage with patients and caregivers. It takes like a team for all of us, right? So that's why all three of us are here together. So I'm going to go ahead and share my screen. So if you guys can all see that, we're going to talk about meeting people where they are, increasing access to mental health and cancer care. So if you can see the slides, we see Susan Sontag looking contemplative there. And this is a quote that I like to start with when we give talks. Everyone who is born holds dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use the good passport, sooner or later, each of us is obliged to identify ourselves as citizens of that other place. I think after the past, 2.5 years of the pandemic, we can all relate to the fact that we're all going to be patients and caregivers at some point. And Susan Sontag there is writing about cancer, but I think equally we could be talking about mental illness. So just as we start today, I just wanted to ask everybody to take a moment to reflect, have you personally been impacted by cancer? Has someone that you care about been impacted by cancer? It's probably most of us, right? Cancer is a really common condition. What about depression? Probably most of us know somebody or ourselves are affected by depression or anxiety or bipolar disorder or schizophrenia or post-traumatic stress disorder or substance use concerns. We know that 1 in 4 people in the United States are affected by a diagnosable mental health condition. So this is really all of us. And just coming to this talk with that context, I think can be really helpful. On the right, we see what's called the Gravity-Defying wheelchair dance. Sometimes we think about illness or disability only as a limitation. But what about if we thought about it also as a part of our identity? What might be possible because of our mood swings or our fear? Like, how might that change the way we view the world? What if that could be something that actually helped us to create something even more beautiful? maybe we can expect more than like the absence of suffering. And that's really what that project is trying to convey also about disability. So I encourage you to check it out and see how, like, you know, a wheelchair isn't just something that navigates a ramp. It can also be something that could create really cool movements that maybe people have never envisioned. And with that spirit, you know, words matter. The words we use, particularly, we're going to talk about mental health, mental illness, matter. The word cloud includes words that were used in interviews with mental health clinicians, oncology clinicians, when they're talking about the experience of caring for someone affected by cancer and schizophrenia. And what words jump out there? Maybe we hear angry or nasty or vulnerable, a lot of negative words. And those words really affect all of our experience being cared for. If you guys have had the opportunity to access Gateway and look at your medical record and the words that are used, and also like the way we deliver care. And part of what we're going to talk about today is what it means to have like person-centered language that begins with people's strengths and their identities outside of illness, and how that can actually transform our experience in the healthcare system. So we talked about this pandemic a little bit. Sometimes people understandably have a wish to go back to normal. But I want to offer a counterpoint that going back to normal would be just about the worst thing we could do in this moment. That when we have profound disruption, we have the opportunity to create something new. That picture on the right is of the Spanish flu pandemic, which devastated the world in 1919. We think about our systems right now, we know that they disproportionately affect people, and it's not equal. So if we're going to do better, we're going to actually meet people where we are. We can't just go back to normal. We need to think differently. And we're going to talk a little bit more about how we might do that together. So if you Google Cancer Center and you Google mental health clinic, this is what you see. You see a beautiful, bright, shiny glass cancer center. It's a lot like Yaki, right? It's shiny glass for those who are familiar with it. And then you see a strip mall. Often, these systems don't use the same medical record. The clinicians that work in one system don't work in the other. And we don't invest the same in care or advocacy for mental health as we do for cancer. And what happens sometimes is that really puts the pressure on the patient and on the caregiver to navigate those two separate systems, to bring in their medical information, to counteract some of the stigma that's so present about mental illness. And when we have kind of separate systems and we don't invest in mental health, that has significant consequences, So we're going to talk about those. I think that we tried to kind of talk through a couple of these myths already, and we'll get through the rest of them. First of all, serious mental illness is common. Affects more than 15 million people in the United States, and it's inadequately treated, but can be treated effectively. Next, people with mental illness die prematurely. They die early, primarily of medical illnesses. And finally, people with mental illness are excluded from a lot of research, including clinical trials, but they actually can participate in clinical research. And we need to question that, because that can be potentially the only way to access life-saving treatment, and certainly a critical way for us to understand how to best support people affected by cancer and mental illness. All right, so life expectancy. Most of you guys maybe are joining us from Massachusetts. If you live in Massachusetts, what is life expectancy for women? So a woman without a known history of mental illness, life expectancy 82. However, for a woman who's cared for by the Department of Mental Health, 52. It's a 30-year mortality gap. And as we said, the number one cause of death is cardiovascular disease, and number two is cancer. So this mortality gap is driven by preventable deaths from medical illness. And what are the factors that are driving that? So some are factors at the patient level, like high rates of smoking. Some are factors at the clinician level, inadequate training and access to care in our fragmented healthcare system. We know that people are less likely to get cancer screening, have less access to tobacco cessation. And even when you come into the cancer center, an individual with schizophrenia is less likely to be offered cancer care, like surgery or radiation, immunotherapy, or be referred to a clinical trial. People with mental health disorders also have less access to palliative care, are more likely to die in nursing homes. And all of these things contribute to a significant cancer mortality gap that people with schizophrenia and bipolar disorder are more than twice as likely to die from many common cancers, in part because of inequities in care. And our contention was that how can we change this? And what we found is that earlier access to mental health treatment could be one promising way to improve cancer outcomes in people affected by mental health disorders, in addition to improving their mental health outcomes and quality of life. So that's the question, right? What might change if we meet people where they are, if we identify them early, and if we make it easier to have access to the person-centered care that includes mental health support, addressing barriers to care, and access to cutting-edge cancer care that we all deserve. You're unmuted.
One of the ways that we have started to address this inequity is developing our Bridge program. And this is a program of a collaborative care program here in the Cancer Center for patients with serious mental illness and a cancer diagnosis. And we piloted this model in a successful pilot study, probably now 4 or 5 years ago. And what we found is that it was a feasible model. Patients and caregivers found it to be acceptable, and that we found that it had a positive impact on the cancer care delivery model. So this led to our randomized trial, which is finishing up now. And that we have been examining both patient care outcomes and caregiver outcomes as well. And also building our Engage initiative, which we will invite all of you to join, and is a coalition that seeks to bridge the gap that exists for patients with cancer and mental illness, and decrease the disparities in cancer outcomes for this population. We've done this by applying a person-centered lens that we believe has the ability to increase access to this population for their cancer care and cancer research. So what do we mean when we talk about person-centered care? This year we had, through a generous grant, a community of practice where we brought together people from diverse backgrounds, patients, caregivers, clinicians, to come together to think about the idea of how we can improve care for older adults and people in the Latino community. And out of that, this group developed a little bit of a guide for how to use person-centered language when working with this population. So it's really about sort of, as Dr. Irwin said in the beginning, language matters, it's important. So, instead of saying a schizophrenic, saying that it's a person with bipolar disorder or schizophrenia. Instead of saying, that's crazy or insane, saying that's unexpected, impressive, chaotic, and really thinking about how we think about cancer patients as well. A person is not their diagnosis. They are a person living with cancer or a patient with cancer. And even in how we document when we talk about patients in the medical record, instead of saying that someone's difficult, saying that they come from a challenging situation, instead of saying that they failed treatment, saying that the treatment failed the patient. These are ways that we can center our work more on the person. Person-centered care also focuses on the dignity and autonomy and individuality of the patient. So asking questions like, what matters to you? What worries do you have? What are your strengths? These are not often ways that we're trained as clinicians to talk to patients, but it makes a big difference. It's slowing the process down and giving patients the message that we care about what they're saying. So typically, this is our Bridge model, and typically when someone comes to the Cancer Center, the patient and their caregiver may come and meet with an oncologist or the cancer care team. They receive their diagnosis and the treatment plan, and leave the cancer center with a lot of appointments and prescriptions and directions. It's very overwhelming. It's overwhelming for patients who do not have a mental illness. So you can imagine how overwhelming it might be for someone who may be more disorganized, maybe confused, or maybe, more overwhelmed. So we thought, let's add a psychiatrist, a social work case manager, and a navigator to form a team that will work with the patient and caregiver and the cancer care team and the mental health team. This is a person and caregiver-centered approach, also a team-based approach. We work as a team. That's one of the reasons we felt it was so important to all be here with you today. The psychiatrist can join in the visit with the oncologist and the patient and caregiver to offer guidance about potential medication issues, and also to be a guide if the patient is not on medication and is needing a psychiatrist during their cancer care. The social work case manager works to help to organize communication between all of these teams, support the patient and the caregiver through different evidence-based interventions and types of therapy. And the navigator is going into the community and bringing the patient to the cancer center. And that could be through appointment connection. It could be physically meeting them at the hospital to help them feel more comfortable. These are all strategies that are person-centered and give patients and caregivers the message that we are here to support them and get them through this treatment. So as we've discussed, the pandemic has really caused not just our program, but medical healthcare as a whole to really sort of, turn our systems around and see where we can make change. And I love that Dr. Irwin said at the top of the talk how this is an opportunity to make change. So there's so much that we focus on in the challenges of the pandemic, but I think it's also an opportunity to see what we can do differently for the future. We really focused on meeting people, and we continue to focus on meeting people where they are. Early in the pandemic, in March, April, and May of 2020, we were not able to see patients in the clinic. We weren't able to see people in their homes or do joint visits. Caregivers were not coming to the cancer center. So we had to figure out how to build the capacity for this population to use technology. And so we really worked to have new approaches to telehealth. Kriya, our navigator, was doing a lot of, digital navigation, helping patients to access their gateway, helping patients or caregivers to access appointments. We work with a lot of individuals who don't have a phone. So we work to try to figure out, how do we reach this person? How do we keep this person connected to care? And we do that through really trying any way possible to communicate, even sometimes sending a letter to the house to let them know that we haven't heard from them and we're concerned. Our navigator would partner with the visiting nurse and sometimes with caregivers or other allies to the patient. And these were also, I think, methods that really help to build trust. Kriya is going to talk about building trust in a few minutes, but we really wanted to figure out how we could develop new solutions, because what we did before was not going to work, and it is not working during the pandemic. And so we had to really figure out quickly how to be persistent and work with new allies.
And I think a big part of being person and caregiver centered is asking what people prefer. What technology works for you? Do you prefer phone? Do you like FaceTime? And it may not always be possible, but if we don't even ask, we're kind of setting ourselves up for developing solutions that don't actually work in the real world.
Yeah. So this is our community of practice model. This was supported through a patient-centered outcomes research grant. And we, as I said, we brought together a stakeholder board, a very diverse board, to work on establishing how we can address access to care for older adults with serious mental illness and people in the Latino communities, during COVID-19. We met for almost a year and developed the person-centered guide that I showed you previously, but also a toolkit, which is available on our website that can be used for, to sort of guide people who want to do research with these populations that have been excluded from a lot of community-based and cancer-based research.
And I think just like, what does co-learning mean? It means like you're actually coming to this process on an equal playing field. So you're engaging in conversation like with people who primarily identify as patients or caregivers or peer specialists or different kinds of clinicians across disciplines, and genuinely coming together to figure out, all right, what works, what doesn't, what do we still need to figure out together? And that's the purpose of a community of practice.
Mm-hmm. I love this quote from Dr. Brené Brown. She's a social work professor at the University of Houston. When we think about connection, this is something that's become incredibly important during the pandemic. She says the energy that exists between people, what is connection? It is the energy that exists between people when they feel seen, heard, and valued, when they can give and receive without judgment, and when they derive sustenance and strength from the relationship. I really love that idea of feeling seen, heard, and valued. And Kriya is going to talk a little bit about how her role as a navigator has helped to build trust during this time.
Thank you.
Hi. So I am going to talk about a 70-year-old woman who had advanced cancer and bipolar disorder and also a history of substance use. She was estranged from her 2 sons, but did have a supportive VNA in the community. As far as her history, she had been treated poorly in the healthcare system, and at the time was really experiencing a lot of pain, fear, and isolation. She was very lonely. So when we talk about kind of building trust, kind of like Dr. Irwin said and Kelly had, Amy had mentioned before, a lot of it just starts with finding out what matters to the patient, what matters to the person. For her, this was somebody who was lonely and she really cared about getting a cat and the potential to have somebody that, she could have to herself and to care for. And she was into fashion. We had conversations about fashion. She loved my sneakers. I loved her sneakers. And so while trying to build a rapport and building trust with her to essentially let her, welcome me into helping her with her care, that's kind of some of the stuff that I did. I went with her to the MSPCA. We got a cat. Like, I advocated that she would be able to care for the cat and kind of told, the agency ahead of time what the circumstances were in case, down the line, the cat had to be returned. We ordered sneakers because she cared about how she looked when she came into the cancer center, and she cared a lot about her appearance. So those are some of the kind of like out of the box things that might not really matter in terms of treatment, but they matter in terms of when you meet a person. It's important, to do what you say. Like if we say like, hey, when you call, I'm going to pick up the phone. It's important to pick up the phone. It's important to show up no matter where the person is. Sometimes we show up at an appointment in the hospital. Sometimes we're going to people's homes. We're in rehabs. We are anywhere that a patient can essentially be seen. During the pandemic, that switched up a little bit and things turned virtual, but we were constantly advocating for people to be able to use iPads for appointments and to still be connected, even though we didn't have that in person. So starting with what matters to people, to patients, and then the tangible things that you can do and the steps that you can take. It's really important, as our team, when I have conversations with patients, they tell me things and I always go back to Dr. Irwin, I go back to Amy, we're always conveying information to each other so nothing gets lost, and things that I know that I have no control over, but they can help with, it's related. And then people see like, oh, okay, like I told Kriya, she reported it, like then things happen, things are changing. Dr. Irwin was on it, Amy was on it. And so they see that it's not just one person doing everything, that we all have a little step along the way. It's important to say, what it is that you're going to do. If you're going to do something, it's important to say exactly what you're going to do and not say things that, you're not capable of doing, or not making promises that you can't keep. Listening and repeating back what it is that you heard to make sure you're not misinterpreting, or making sure that you're on the same page, making sure that your interpretation of what the patient said is actually what they meant, because sometimes people say things and that's not entirely what they meant. So hearing it back is helpful. eye contact is one of the most important things, especially now that we're all wearing masks and we can't see each other smiling. We can't really see those facial expressions that we make. So maintaining that kind of soft eye contact is really important. And then just acknowledging that like trust isn't something that happens overnight. It's something that you have to keep doing. It's kind of like a try and a fail. It's super hard. You don't get it right like at the first try, but it's important to be consistent and to keep trying and just remembering like you're doing this for a bigger reason.
Absolutely.
And here, creative engagement, you know, me and Asabella as navigators, it's a lot of just thinking outside of the box and just making partners with who you can be partners with, whether it's in the community, whether it's inside the hospital, whether it's outside agency, really just connecting to the people that are important to our patients so that, you know, we are all supporting them in all angles. And then policy change. We all want to change policy. So keeping that in mind with doing things that, you know, we are able to kind of prove why this works by having the data, by having reports. So yeah.
Yeah, and just building on that, I think one of the things is acknowledging when you can't do something or when the system doesn't work. Acknowledging the fact, for example, it's really hard to find mental health care, let alone excellent mental health care. Like right now, it sucks. Like clearly we don't actually have mental health parity in the United States. You know, so we have a lot of work to do. And I think that if we're able to acknowledge what we're not doing well or what we want to do better, that's actually trust building as well. So just to kind of go quickly back to some of the research that Amy had introduced, this is the initial pilot that we had done of person-centered collaborative care. We had aimed to enroll 30 people with schizophrenia, bipolar disorder, severe major depression, and a new solid tumor. And you can see that we enrolled that population quickly, that 90% of the people that we approached consented to the trial. 100% had completed their assessment with our team. Importantly, 6 people in that trial had not received the cancer care they needed. They hadn't gotten the surgery they needed, you know, and 5 of 6 got all cancer treatment that had been recommended, and everyone got more than they had, you know, and these are people who had, you know, curable cancers who hadn't gotten care. And so this made a significant difference in their quality of life and how long, and their survival. So I want to turn it over to Amy to talk more about like who are the caregivers for people who are affected by mental illness and cancer.
Thanks, Dr. Irwin. Caregivers for this population have not been studied. There's a lot of research for cancer caregivers and a lot of research for caregivers of people with a mental illness, but none that looks at the intersection of both. We first looked at caregivers in our pilot study and did qualitative interviews following that study to kind of get a better idea and a better sense of their needs and what their perception was of the collaborative care model that we were studying. What we realized is that, you know, this is a population where caregivers are not just spouses. It is a diverse population made up of spouses, family members, including adult children, parents, nieces, friends, and community health workers as well. For many individuals, a community health staff member is the person who they see each week. That is the person who helps them make treatment-related decisions. And we found that caregivers as a whole felt very unprepared for what was coming to them with this cancer diagnosis. And community mental health staff were really feeling like they did not have a great understanding of cancer care. And, you know, we talked, and so this community mental health staff person says it's been extremely difficult because she doesn't have any insight in the risk if she doesn't get treatment. Community mental health staff feeling a lot of pressure to help this person get through their care. And I think caregivers as a whole feel that pressure as well.
I mean, I think we're working with someone right now, it's similar, you know, just very, very overwhelmed and saying they don't have cancer. And the person who works in their group living environment really wondering, what can I do? I don't want this person to suffer. I want them to have the best chance at getting the treatment they need, but I don't know what to do next.
Yeah. So some of what came out of the pilot study were really thinking about how caregivers felt there were challenges and also rewards. So, you know, that some of the challenges included how mental health symptoms impacted treatment. And I think that one of the things that they identified as being valuable was having access to a psychiatrist who was, treating the patient, but also listening to the caregiver's concerns. Felt overall there was a lack of information and resources that were related to this population, which is true. But some of the rewards, I think, were things that we weren't expecting. Caregivers who previously were estranged from the patient, who now felt that their relationship had become more meaningful, that they had a better understanding of their loved one, and also that caregivers felt very cared for in our person-centered model. They felt that they had the ability to reach a team and to get help in the moment. They felt heard. Some of the lessons that we learned from these interviews and from this pilot study, things like how to better support caregivers with this population, supporting the patient where they are, how to help the caregiver to tend to their own needs, and advocate for better communication. These were things that we then took to our randomized controlled trial, where we are now studying patients and caregivers to look at how the outcome for the caregiver changes over time, looking at their, what they experience as a caregiver. And so that's been a really important part of this randomized trial, which is focused on disruptions in cancer care, but again, also how our model impacts patients and caregiver outcomes. Caregivers, we have a diverse group of caregivers in our randomized trial as well. So really, focusing on the protocol being, that the person spend at least an hour a week with the patient, and that they be involved in the treatment planning and decision making. And we've been very fortunate to get, to have terrific data that I think will continue to open up more opportunities for us to research caregivers in this population and better meet their needs.
Yeah, absolutely. I mean, I think that we can all imagine in that situation what it would be like to not just do like a thoughtful assessment of the patient's needs and strengths, but what if we also assess what the caregiver needs, and gave space and time to think about all the different competing priorities that caregivers have, in addition to supporting the patient. What are their mental health needs? What are their strengths? How do we design like an individualized plan and think about how to integrate that, along with the patient? What if that was standard of care, that always happened? We always did an assessment like that for caregivers. I just also noticed in the chat, totally agree that thinking broadly about the different kinds of communities that are supporting people, including religious communities, that can be such a key source of support for patients and caregivers.
So, again, there were so many challenges during the pandemic, and also, again, opportunities to try new approaches and to connect caregivers in a better way. Virtual models actually made it harder at times for caregivers to be involved. Caregivers could not come into the cancer center, which meant that they either had to have the patient FaceTime with them during a meeting with their team or be on the phone, because you're not able to have a virtual visit for the caregiver and a patient in the room visit as well. So a lot of caregivers were really feeling left out from treatment planning and decision making, weren't being heard about their worries about the patient. There were no visits to rehabs or nursing facilities. And I think there were a lot of challenges in rescheduling appointments and figuring out who to call if there were missing prescriptions or if there was an emergency. So we really focused on working with caregivers during the pandemic on better access to the cancer care team as a whole. And when we were able to be back in person, we did a lot of work, being in the room with the patient and calling the caregiver ourselves, or emailing the team after the meeting to encourage them to call the caregiver directly, as part of the care team. These were just a couple of things that I think made caregivers feel more included during the pandemic. because it's really a time where there's a lot of disconnection for caregivers.
And I think particularly hard when people are approaching end of life. Very challenging when you're worried your loved one can't communicate or advocate effectively with the team and you're used to being there. So I think a number of really key challenges. And if maybe it's not clear who the caregiver is, to make sure the patient goes in with that caregiver's name and phone number, and that you have your cell phone on, just in terms of practical strategies that can help bridge communication across care settings. So, I think if we kind of put this all together, as we continue to navigate the pandemic, we continue to think about like what a team looks like, how to rebuild trust, how to bridge a fragmented system. I think we need to think beyond the four walls of the hospital. I think we can do that in a number of ways. We can do that through technology by increasing the reach of virtual consultations. We can do that by physically being in the community. We can think about who isn't in the room traditionally and whose voice needs to be elevated if we're going to rebuild trust. So some of the collaborations that we've built, I think it's really important that we're bringing in different disciplines together. So for example, one challenge we noticed was lower rates of cancer screening amongst people with serious mental illness. And what if you didn't have to call and make an appointment? What if just when it was a good moment, you could just come on over and get your mammography? For people who are perhaps not frequently home, are living on the streets, like this is a really critical strategy to utilize that moment in time and get that cancer screening. And so that's been a successful initiative. What if we had the opportunity to have conversations about lung cancer screening with someone you trust in your community mental health clinic? What if you talked about that with your psychiatrist and also use that as an opportunity to help cut down on smoking? And then you had streamlined access to lung screening. This is another key opportunity that has the potential to improve lung cancer survival in this population. And then, finally, what about this model of a tumor board, which people have been utilizing in cancer care for many years, that brings together different disciplines, a medical oncologist, surgeon, pathologist, radiation oncologist. What if we also included mental health and social work and navigation and really had a conversation about this full person? That's another model that we're implementing currently. So this is a picture of that. So if anybody's from the North Shore, that's one of the locations that we're piloting this model. One of the challenges, as we mentioned before, is frankly, although everybody affected by cancer is supposed to have access to mental health care, the reality is it's not the case. And even in our affiliates at Mass General Danvers, Waltham, Newton Wellesley, they don't have embedded psycho-oncology services. So how could we increase the reach of our team? One strategy is to proactively identify people. We use, an algorithm that's built into the medical record. We find 1 in 5 people affected by cancer have a pre-existing mental health disorder. What if we identified those individuals ahead of time? And we created this team that comes together monthly with a monthly video conference around the North Shore region. We include the Danvers team, we include folks from Salem Hospital, we include the social workers, we include our team, we include a community mental health agency that serves the area. And therefore, we kind of create this regional network that can help to support people with the person and caregiver's needs at the center. We found this to be a very promising approach that has helped people who haven't been able to access care to get it, and also whether that be mental health care or cancer care, and also strengthen relationships in a community where people have a really shared mission. I see a question in the chat. When are we expecting to publish the randomized trial? Soon, hopefully. No, so we have finished accrual. We have 120 patients enrolled in that trial. So we're just waiting for people to finish their 6 months for the primary outcome of the trial. But I would say later this year, which is exciting. So we mentioned a coalition. So I'm a physician. I didn't go to community organizing school, but it would have been useful if I had. But when there are persistent inequities, it's going to take more than people inside a hospital doing something about it. It's going to take us bridging relationships with organizations and individuals with a shared mission who are, coming from different places. And that's really the purpose of this coalition, to join together with mental health advocacy organizations like the National Alliance on Mental Illness, with the Department of Mental Health, the American Cancer Society, with other mental health agencies, with individuals who care about this, to take this pledge. And we invite you to take the pledge too. Probably if you've, gotten through this talk, you probably agree. You can take the minute, to say, I pledge. I'll say it myself too. It's good for me to remind myself, I pledge to ensure that mental illness is never a barrier to cancer care. And I will add, I extend the same thing. It should not be a barrier to participating in research either. These are human rights. And as a physician, I believe that we all have the human right to healthcare, cancer care, and mental health care. And so this advocacy is an important part of my identity. And I think it's been really rewarding to collaborate with state legislators and on the national level as well, to see how this has actually transformed, for example, like the Irish Cancer Society's vision of how to deliver mental health care. So it has like a pretty strong reach. And I think we have the opportunity to really represent the voices of a population who is often invisible and make sure that we're thinking about them when we're designing mental health and cancer care delivery. So for individuals who are out there, there are resources that are available that are helpful. And certainly if you have other questions, feel free to put them in the chat. We're happy to help problem solve. But a couple of important resources are NAMI Mass, Cancer Care, the Crisis Text Line, Samaritan's Line. If anyone has thoughts about suicide, we didn't talk a lot about this, but the risk of suicide is double amongst people affected by cancer. So it's really important to screen and make sure that we're asking people how they're doing and linking them to help. And that it's important that everybody knows that there is evidence-based help that's out there that people can help to access 24 hours a day. And finally, I want to thank our many collaborators from Mass General, from the Dana-Farber Harvard Cancer Center, from the American Cancer Society, from NAMI, DMH, North Suffolk, go on and on. Our colleagues here at the Blum Center for inviting us to speak, and really to invite all of you guys to join us in this work and in this coalition to learn out about free events, to come together, and specifically we have a caregiving event coming up next Friday. It's Friday the 13th, so it's easy to remember. In the morning at 10 a.m. One of the things our events always do is include stories. Stories in people's own words, so that we really have the opportunity to think together about what it means to be a patient or caregiver or navigator or peer specialist, and how we can learn from that together, and really also engage in some conversation about kind of what needs to change. So we really invite you to join us. That's next Friday from 10 to 11:30. You can snap that QR code, or you can just reach out to one of us if the QR code's not your thing. They're still not really my thing. I still prefer a regular menu. It's not annoying. I'm like, I don't want the freaking QR code. Maybe that's just me. All right, so with that, that's the end of our slides. So I can stop sharing if you like, and we can see each other.
Be great to hear from anyone with any questions.
Thank you all so much for this very important work. It seems like you run the gamut, and every facet is covered in so much of what you do, and so much thought goes into it. So it's wonderful to hear more about the breadth of everything. A couple of questions. How has the model of the program, how has it changed care in the Cancer Center?
So maybe I can start, and then you guys can jump in. So I think that my hope is that it's more standard of care to ask if people are affected by a mental health condition, and when they are, to then also reach out to our team. So, I think we can see that, that if people, if an oncologist, a surgeon, a radiation oncologist sees someone, particularly if they have any concerns about them, like, hey, Kelly, we'd love for your team to be involved. Or have we reached out to oncology social work? So the idea of a proactive model and a team-based approach to care, I think, are two kind of key changes.
And I would also add that I think that it has, I can say certainly for myself, that I think it's increased our reach to other disciplines. So we have been, because we see patients wherever they are, inpatient, outpatient, in skilled nursing facilities, shelters, even in their homes. I think we have been working to build a network both here in the Mass General and also outside, so that, we can better serve this population through, hearing what other disciplines have to say, hearing what their experiences are, and I think kind of demystifying this population a little bit, and helping, I think, providers and other people who are allies connected to patients with serious mental illness, helping them to kind of see that there is a resource available to them and that we want to be there to support them.
Thank you. How do you collaborate with other disciplines within the Cancer Center? And to that point too, is there any sort of collaboration with PCPs or other doctors sort of before even getting into the Cancer Center?
Yeah, that's a great question. We have worked over the lifetime of our program to have better connections with primary care physicians who are often some of the only physicians who are seeing this population, and may be also prescribing their psychiatric medications as well. So, and we've worked on this trial with several primary care physicians who've been incredible advocates for the patient and their family. So I think we work really hard when we first meet the patient to figure out who are their allies, who's on the team, who is important to connect with. Sometimes the team can feel very large to the patient. Patients may be receiving care where they have someone from speech and swallow, someone from radiation, someone from medical oncology, someone for nutrition, someone from social work. And so I think that one of the things that we've worked hard to do is try to kind of bring those people together so that we're all on the same page with the patient's care. So they're not getting one answer from this person and another answer from this person. And I think, as I said previously, I think it's really improved our connection with other disciplines. Dr. Irwin, did you want to add anything?
I would say even within mental health care, I think communication can be really fragmented. Oftentimes, like folks who are working in like residential care and the group home staff or supports rarely talk to the psychiatrist, or the psychiatrist rarely even knows they're involved. And it's shocking to me. It happens all the time. So part of our job is really to be like, start with the person, be like, all right, who's the person you go to when you have a question or you need something? Who's really the person you trust? And then how do we kind of think about the whole team around that and really make sure that like people who know the person well are being listened to. So, that may not always be like the physician, like who's the person who actually gets what's going on, who has the opportunity to really accompany people through care. That's the person we want to kind of make sure that their voice is amplified. I think primary care doctors in particular are important, and oncologists too. So people don't always have a formal diagnosis. Sometimes people don't want to see a psychiatrist. I mean, I get that all the time. I don't want to see a psychiatrist. I'm like, alas, I'm just part of the team. It's just what we do here. How much I lead with I'm a psychiatrist varies, but it's usually not the first thing I say, unless it's someone who really wants a psychiatrist. So, I think that we try to be flexible because oftentimes, in part because people are so busy and overwhelmed, people are quick to tell you that this is not their job. This is not their role. This is not what they do. If the person can't do this, then they can't help. Well, our philosophy is that like cancer, mental illness is hard enough. We don't want to add burden. Why don't we start with what we can do? I think if we all kind of had a little bit of that deep breath, just like the first thing you say can just not be what you can't do. That's just so unhelpful. The question I ask myself, how can I be helpful? And sometimes it's a struggle for me to find something. Maybe it's just by being curious and kind, but there's got to be something, that I can offer, and also ideally something I can learn, because that, as all of us as clinicians, like it's a challenging job. It doesn't always go well. There are a lot of losses, and people are treated really badly in the world. And I can't obviously fix that. So how do you keep doing it, right? One way that I keep doing it is certainly a team. The other thing that's really important is I'm genuinely curious. Like Kriya was speaking about our shared patient, like, we had a lot of fun moments together. I did get a pair of Vans. I was like, those are kind of cool Vans, maybe I can pull that off. What do you think? Those moments of shared humanity are critically important, but even more so for people who may not have anyone else they're engaging with in that way. And oftentimes as clinicians, and I think as people, the first thing we can do is uphold people's dignity.
Thank you. Can you speak a little bit to how often you come across a patient who doesn't have a support system or caregiver? I know you've done a lot of research into that, but how does it change your roles, or what challenges does that provide?
Yeah, I mean, I think it's harder sometimes. And I think probably sometimes we end up sometimes doing a little bit of that, you know, stuff in a way that can be hard to sustain. So it might be that Kriya goes to the appointment with the person. You know, it might be that we, you know, call that person a little bit more regularly. We remind them to pick up their prescription. We check in, we text to make sure they got home safely. Those things that, you know, don't always happen to people in the world, but have a lot of meaning. I think people feel these moments where it goes outside of your job description. Oh, you didn't have to do that. You came in on your day off. You called me back on a Sunday. And obviously we can't do those things all of the time, but if we're intentional about when we do that, I think it has a ton of meaning for people to feel like they're treated as individuals, not just as patients. And yeah, I'd love to learn more about an allied work in Denmark. Love it. Thanks, Louise. I look forward to learning about that.
We have just a couple minutes left. I guess one thing that might be helpful for people to know about is how anyone that's logged on today, how can they get more involved?
Sure. That's a great question. I think, you know, and sort of a two-part answer. I think to get involved in our, in the Engage initiative, you know, it's really easy to get on the website, get on our mailing list. We really don't send a lot of emails out, but we do typically have a couple of virtual events over the course of the year. We have 3 work groups: a research work group, a clinical recovery group, and a caregiver group, who are also working in different ways to bridge the gap that we discussed. And so, you know, if you can get involved by just signing up and being part of our coalition or being part of our work group. I think if you're here today and you are thinking of a patient that you work with or a loved one, and you're worried about their medical care, you can also reach out to, if they don't have an oncology team here in the Cancer Center, you can reach out to us. We'd be happy to help connect you. If they do have an oncology team here in the Cancer Center, talk to your team, and we can see how we can be helpful. And that's kind of how we start when we meet people, is how can we be helpful? And, you know, when teams contact us, we say, how can we be helpful? And that's really what we lead from in our clinical meetings and in our model and in the work that we're doing within the Engage initiative as well. So those are just some ways to get involved. And I think even more, if being part of the coalition isn't your thing, even just thinking about like the person-centered guide that we showed earlier and how you can you know, make little changes in the language that you use when you're talking to people and patients. Sometimes that's a really good way to think about contributing to, you know, to making sure that patients have the same rights to cancer care as anyone else.
And if you like read your record or your loved one's record and you don't like the language that's used, you know, or I suppose if you do, I mean, I think it's good to give feedback about that, you know, because I think that that's how change happens. You know, and it's definitely, it's a process. None of us is perfect. Like you know, we're evolving, so we can all kind of improve together. But I think creating space for people to be like, you know what, that didn't make me feel good when you use that language, or that kind of shut me down. I think that's an important conversation to be able to create space to have. So I would encourage you to bring up those concerns. You know, and if it's hard to talk to your team, you can always talk to patient advocacy about that too.
Oh. Thank you so much, Devin and Amy, for hosting us. You know, we're thrilled to be, you know, to have a spotlight by the Blum Center and to just be able to talk to everyone here today about our program.
And Mental Health Awareness Month, so it's all good.
Right.
We appreciate everybody joining us.
Yes.
That's right.
Thank you all for being here and for the absolutely wonderful work that you do. We are up at time. Does anyone have any final words before we log off? Said it all. Well, thank you everyone for joining. Have a great rest of your day.
Right. Thanks so much.
I did want to share that for those who are interested, the session is being recorded. And if you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a good rest of the day.
Bye.